So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry, supported by Novartis, is organizing the third multiple sclerosis virtual clinic, our one-of-a-kind learning experience. During this educational activity, our top-notch MS experts will share with you real-world clinical cases. Therefore, I would like to invite you to interactively participate by analyzing the cases shared and vote whenever needed, as your participation will definitely make it a fruitful meeting. Why did we choose to discuss secondary progressive multiple sclerosis today? First, because SPMS is a debilitating condition characterized by gradual worsening after an initial relapsing disease course. Second, because despite the recent advances in our understanding of the disease, the diagnosis and treatment of SPMS continue to be challenging in routine clinical practice. The aim of this virtual clinic is to present the clinician's perspective of two MS experts on the challenges in the diagnosis and management of SPMS. It also provides real-world experience with the use of siponimod, the first and the new treatment for SPMS in over a decade. Before starting, let me thank Novartis for sponsoring this educational activity. In our first session, Professor Mustafa Shakra will discuss when and how to treat patients with secondary progressive MS. Dr. Shakra is a consultant neurologist at Sheikh Khalifa Medical City, Abu Dhabi, UAE. He has particular interest in inflammatory and degenerative diseases of the central nervous system. He runs the clinics of multiple sclerosis at SKMC. Dr. Shakra has graduated from Medical School of Damascus University in 1992 and received his main training in general internal medicine and neurology subspecialty in the major university hospitals. He carried an MD, a master's degree, MRCP, and FRCP in medicine and neurology. And additionally, he has authored and co-authored many articles in the field of neurology in general and MS in particular. Dr. Shakra, it's always a pleasure to have you with us as a speaker. Welcome, and the floor is yours.
Thank you, Maya, for your kind introduction. Thank you, IVPN platform for inviting me for this lecture, and thank you Novartis for the sponsoring for these meetings. Let me first share my slides. Okay, so okay, do you see my slide?
Yes, doctor, perfect. Thank you.
Okay, thank you very much. Good evening, my friends, colleagues. I would like to thank also again platform of IVPN and Novartis for sponsoring these meetings. My topic today is about when and how to treat secondary progressive multiple sclerosis patients with siponimod. My name is Mustafa Shakra, and I am working at Sheikh Khalifa Medical City in Abu Dhabi. This is my disclosure for this presentation, and this is my objective learning. We'll go through all of them briefly in the coming 35 minutes. So initially, let me start with this classic slide that you use to see and probably in every MS presentation. It is the natural history of relapsing rheumatic multiple sclerosis and the primary progressive multiple sclerosis. As you know, majority of cases of multiple sclerosis are relapsing remitting. However, 15 to 20 years after diagnosis, patients start transitioning into secondary progressive multiple sclerosis, where the relapses rate is reduced and the accumulation of disability becomes very prominent. While in primary progressive multiple sclerosis, hard to appreciate any clinical relapse from early beginning, and there is a gradual worsening of disability over time. So secondary progressive multiple sclerosis is a burden on the health system, on the patient functionality, on even the cognition and and the job responsibilities and daily activities of living. Although there is clinically no relapses and still progression of the disability over time, unfortunately, till this moment, we don't have any biomarker to confirm the diagnosis or the transitioning into secondary progressive multiple sclerosis. Therefore, there are a lot of unmet needs. Only the most important one is that diagnosis is usually delayed, and it is usually retrospective and done on basis of lack of relapses and accumulation of disability in a patient where there is minimal change in MRI or any probably clinical complaints of the patient. Subsequently, there is also lack on communication between the doctors and the patient in order to confirm the diagnosis. And again, other unmet need was related to lack of medications over the past 20-25 years, and all medication that we know or we used to know or prescribe to treat relapsing remittent multiple sclerosis had failed the trial when it was done on population of patients representing secondary progressive multiple sclerosis. The other probably unique characteristic of the secondary progressive multiple sclerosis is a type of symptomatology that is usually complaints are related to symptoms that impact the physical functionality of the patient, something like muscle spasm, spasticity in legs, constipation, sexual dysfunction, difficulty in mobility, bladder dysfunction, all these symptoms that are usually not very much communicated during clinics between a neurologist, the treating neurologist, and the patient. These are the most prominent now complaint when the patient is transitioning into secondary progressive multiple sclerosis, when it compared for probably sharp complaints of relapsing remitting multiple sclerosis of something like optic neuritis, acute ataxia, acute motor weakness, or other complaints. Additionally, there's a bunch of soft complaints, something like fatigue, numbness, pain, vision problem, dizziness, and depression. And this is usually the more prominent among patients with secondary progressive multiple sclerosis in comparison with patients of relapsing remitting forms. Not to forget the cognitive dysfunction that is affecting the majority of population of patients with SPMS in comparison with relapsing remitting multiple sclerosis. The cognitive impairment is affecting almost all domain of cognitions, as we see from this slide. We mentioned before that this disease is impacting negatively the activities of life, daily life of the patient, in addition to work responsibilities and duties. And as we see from this study, the employment rate is almost 50%, as it is expected in peers of relapsing remitting multiple sclerosis, which add a lot of burden among the social probably support or the health system or the probably a budget or whatever needed for this group of patients from financial point of view, of course. So the mechanism of disease, it's not like what we know of relapsing remitting multiple sclerosis. We know from relapsing remitting multiple sclerosis, there are waves of activated lymphocytes that are breaking down the blood-brain barrier to induce plaque damage in the brain, which is consisting of demyelination area and activated lymphocytes. Additionally, there is subsequent axonal damage with subsequent recovery. However, when it comes to secondary or progressive forms of multiple sclerosis, the mechanism is different. There is trapped inflammation outside of the brain, and there is no more waves of activated lymphocyte in the peripheral blood. These trapped immuno cells or immunoinflammatory cells is releasing chemokine and chemotaxin that is inducing the neurodegeneration inside the brain, regardless of the inflammation in the peripheral blood. Subsequently, there is slowly accumulation of neurodegenerations with subsequent prominent clinical disability. Now, when they looked for disability, generally speaking, we know from multiple studies or many databases that we have that there are two types of disability when it comes to multiple sclerosis. a disability that are related to relapse. So it is RAW, relapse associated worsening, and there is BIRA, which is in fact what is this? Progression independent of relapsing activities. So there are two types of accumulation of disability. One is related to relapse, as you see here. The relapse within, sorry. Okay, when you see, as you see here, there is relapse here. And within the relapse, the clinical situation did not go to the baseline. And subsequent during the relapse, within the 90 days, the patient is starting to accumulate a disability that was induced by relapse. However, in many occasions, there is a relapse with recovery within 90 days. Then subsequently, slowly, there is accumulation of disability, which is known as BIRA, which is a progression independent of relapse activities. And what they find from the database of related to studies, clinical trials, including phase 3 trial or other trials, that mechanism of disabilities among patients with relapsing remitting multiple sclerosis and progressive forms are in fact different. If you look on this slide, which is the database from Novartis, it's known as NOMS. And as you can see, when it comes to the relapses rate is very high among patients with relapsing remitting multiple sclerosis, regardless if they took the full database or the phase 3 trials. The relapses are more prominent in numbers, where it is minimal in secondary progressive and the primary progressive. Now, when it comes to the disability related to the disease, you will find even the size is different from relapsing remitting and the progressive forms. It's more prominent on the progressive forms. Now, breaking down, you find that the relapse-associated worsening of disability, again, is representing a small bunch. In patients with relapsing remitting multiple sclerosis, what is bigger while it is smaller in secondary progressive multiple sclerosis and even in primary progressive multiple sclerosis. As we said, there is no clinical relapse. Almost it is very minimal or hardly appreciated, especially in primary progressive multiple sclerosis. So the RAW or the relapse associated worsening is minimal and doesn't contribute to the disability in the secondary progressive multiple sclerosis and primary progressive multiple sclerosis. Moreover, now if you look at the green bunch of these groups, and you will see that when it comes to relapsing remitting multiple sclerosis, this is representing BIRA. BIRA is again representing again minimal part that is contributing to the disability related to in among patients with relapsing remitting multiple sclerosis, while it is again contributing remarkably to the disability progression among patients with progressive forms, either secondary progressive or primary progressive multiple sclerosis. The conclusion was clear. BIRA begins early, as we see even in relapsing remitting multiple sclerosis, although it is not contributing significantly to the disability, but it begins early and becomes the dominant driver of disability worsening, especially in secondary and primary progressive multiple sclerosis. The database did not only look at the contribution of BIRA or RAW to the disability among patients with multiple sclerosis, but also they look at risk factor of incomplete recovery from relapses. And what they find after looking at the full database or phase 3 trial or phase 3 placebo-controlled trial, that pre-existing disability and older age at the time of relapse were the principal risk factors for incomplete recovery from a relapse. There was also some numerical support for male sex is associated with less possibility or probability of recovery from relapse. Additionally, also there was numerical but not statistically significant history related to bowel dysfunction or bladder dysfunction as parameters associated with incomplete recovery from relapse. The conclusion of this trial that looked at BIRA and RAW and the incomplete recovery had shown that relapses in the first year increases the chance of disability accumulation. Therefore, it is better to treat as early as possible in order to avoid the future accumulation of disability. BIRA start early, as we saw in that it start even in the relapsing remitting multiple sclerosis and becomes the dominant driver of disability in the progressive forms. The principal risk factors for further disability was related to prior disability and older age. So how to diagnose secondary progressive multiple sclerosis? Unfortunately, as we mentioned in the unmet needs, that till this moment, we don't have consensus about definition of secondary progressive multiple sclerosis. This article looked at the different definition by different clinical trials, and what that conclusion was to use more than a parameters or more than a definition in order to increase the accuracy of the diagnosis and increase the sensitivity and the specificity. And they suggest to use at least 3 of them, as they suggest in this, as you can see from this slide, 3 of these definitions in order to get higher accuracy when it comes to the confirming the diagnosis of secondary progressive multiple sclerosis. Unfortunately, due to the lack of definition, also this is reflected also in lack of confirming the diagnosis. As I said before, the diagnosis is usually retrospective. Therefore, in majority of cases, there is delay in confirming the diagnosis by 3 to 4 years. This initially is related to the tool that we are using in assessment for the accumulation of disability, which is ADSS scoring. We know that we start thinking about, usually according to our classic teaching, that we have to start thinking about secondary progressive multiple sclerosis whenever patient reach the score of 6, which means that it is becoming dependent on a tool or support to walking. Now we know this is not true, as we have many trials, many studies had confirmed that early signs of secondary progressive multiple sclerosis start even with ADSS score of 2 or 4 or 3. Again, we know that the ADSS scoring is based on mobility capacity. There is no input for upper limb function or cognition, which are important complaint among patients with secondary progressive multiple sclerosis. Additionally, it is not handy, it is time consuming, and it is related to operator. So the information or the conclusion that I can give, probably the next door my colleagues will give the different number from this what I give. Some people looked at the neurofilament lights as biomarker to confirm the diagnosis of secondary progressive multiple sclerosis or primary progressive multiple sclerosis. As you know, this filament as a product of the degradation of axonal damage, and it is usually leaked to the CSF and to the blood. However, unfortunately, till this moment, there was no standardized commercial availability for this tool as an indicator for secondary progressive multiple sclerosis. We know from expanded trials that there is direct and tight correlation between neurofilament lights in the blood and the disease duration, ADS scoring, SDMT score of cognition, the brain volume, and MRI measures. We have also similar, probably also correlation when it comes to relapsing form, when it comes to MRI lesion, relapses, and brain atrophy, and disability progression. However, it's yet again is not available commercially as a tool to confirm the diagnosis. Coming to siponimod, which is the second generation SB1 modulator. It is a small weight molecules, which is crossing the blood-brain barrier, and it is highly selective in comparison with its ancestor, fingolimod, Gilenya. It modulates the S1B1 and S1B5. Therefore, we think that it has dual mechanism of actions. One is related to peripheral blood when it is acting exactly like Gilenya is acting by sequestrating the lymphocyte inside the lymphoid tissue in the blood as here. However, due to the crossing of a blood-brain barrier, it might modulate also B5 in astrocyte and oligodendrocyte and promoting remyelination and protect against the neurodegeneration. It has a remarkable selectivity when it comes to comparison with Gilenya. It has shorter half-life, which is important nowadays in case you need a pregnancy, a washout, faster washout period, vaccinations, and because of its short half-life in comparison with Gilenya. So the expanded trial, in fact, the trials, phase 3 trials that tested this medication among a population of patients with secondary progressive multiple sclerosis in order to find out if it's effective or not effective. So the study was a phase 3 study looking on efficacy and safety on siponimod on patients with secondary progressive multiple sclerosis. It was randomized, double-blind, placebo-controlled, and exposure event-driven. It has 2 arms, placebo and active arm, distribution 2:1, and the main primary endpoint was 3 months confirmed disability progression. The study was terminated or ended when get at least 374 event of 3 months confirmed disability, considering that 95% of patients enrolled in the study had an exposure at least 1 year to the study medications. Subsequently, there was an open label trial extension up to 7 years. We'll go through this one after the study. During the study, patients used to do the MRI every 1 year, EDSS scoring every 3 months, and SDMT cognitive test every 6 months. The primary endpoint was 3 months confirmed disability progression, and there was a bunch of secondary progressive multiple sclerosis secondary endpoint. We'll go through all of them in coming slides. So the main criteria, as usual, here the EDS score between 3 and 6.5, and the definition that they used for the enrollment in the study was a progression of the disability over 6 months duration in absence of relapse or independent of relapse. So this is the definition that they consider in order to enroll patients with this study. The main exclusion criteria were related to uncontrolled cardiovascular disease, pulmonary disease, hepatic dysfunction, diabetes, macular edema, and absence of antibodies against herpes zoster. And there is another here exclusion related to genotype, secondary to Stockholm 2C9. When the result is a star 3, that means the patient is very slow metabolizer, and in this case, they are not fit to receive siponimod due to possibility of toxicity. The population of patients were very representative for what we know for patients with secondary progressive when it comes to the age of more than 40 years. Majority of them, when it comes to duration of disease, as you can see, majority of them more than 17 years. When it comes to the EDS score, the median was 6, which is meaning that many of them were in fact dependent on a cane or a tool in order to support their walking. There is also some group of patients with active MRI findings like T2 or T1 enhancing lesions. The result of the study was significant towards the superiority of siponimod over the placebo. As you can see here, the superiority when considering the general population of the patient was 21% reduction in confirmed disability, while in the group with active secondary progressive multiple sclerosis was higher and was more prominent up to 31%. The diagnosis or the criteria for active secondary progressive multiple sclerosis was either a history of relapse within 2 years prior to enrollment of the study, or an evidence of any active findings on MRI, including T2 or T1 enhancing lesions. Same when it comes to the secondary endpoint of the 6 months confirmed the disability progression. Again, the result was more prominent among the patient with active MS. It was 37% reduction over the 30 months of trial. When it comes to annual relapse rate, again, it was the superiority of siponimod was very prominent into the 2 groups, overall group and the group with active secondary progressive multiple sclerosis, as you can see from this slide. And again, when it comes to MRI lesions here, we are talking about GAD enhancing lesion. Again, the superiority of siponimod is very obvious. T2 lesion act in same way, either the T2 lesion volume or the T2 enlarging lesions. Also, again, there is a remarkable superiority and very much statistically significant when it comes to siponimod arm. Brain atrophy, regardless of the tool that you are using, either cortical gray matter atrophy or thalamic atrophy or total brain atrophy, there was superiority of the siponimod over placebo. It was more prominent in the second year on month 24 in comparison with the placebo. And not only this, but majority of patients who were in the active arm had shown either improvement on cognition or at least stability on cognition when compared to the placebo arm. However, also when they looked at the 6 months confirmed 4-point SDMT worsening, the percentage of patients who showed the worsening in cognition was less in the siponimod in comparison with the placebo. So based on this, there was an approval of siponimod as a treatment for active relapsing secondary progressive multiple sclerosis, and it was approved in March 2019. It is for patients who are in transitioning for secondary progressive multiple sclerosis or patients already in secondary progressive multiple sclerosis but the active disease. Don't forget that using of siponimod, in fact, delaying the time for wheelchair by at least 7 years when compared with placebo. Safety-wise, the safety profile was almost identical to what we know from older ancestor fingolimod, and there was no serious or new alarming findings from this study when it comes to the new S1B1 modulator. And again, the main, probably for a majority of you know the profile of adverse event of S1B modulators, which include higher rate of transaminitis, bradycardia, macular edema, hypertension, herpes zoster, and in minimal cases, few cases, convulsions. Subsequently, up to this trial, there was also a subsequent extension up to 7 years. Currently, we have the analysis of 5 years available. I'm going to present it now. And the objective was for open label extension was in fact to aim to assess the long-term efficacy and safety of siponimod. Now we have up to 4 or 5 years, and the effect on earlier versus later initiation of siponimod. You remember that part of in the trial in expand were in a placebo, so they start late on siponimod while the initial group of active continue on siponimod. So this group continue on from siponimod to continue on taking siponimod in the extension time, while this group of placebo moved to again siponimod. So the comparison was between the two groups as early initiator and late initiator of siponimod. And this is the protocol of the study. Again, they follow the same one every year MRI, 3 months ADSS score, and 6 months SDMT. This is the study endpoint: time to 6 months confirmed disability progression, time to 6 months confirmed cognitive worsening, and annual relapse rate, MRI measures. And again, there was subgroup analysis related to active and non-active SBMS. And the result again had shown confirms the superiority of early initiator of siponimod over the late initiator, and there was 22% reduction in the 6 months confirmed disability progression. And when it comes to the late initiator, there was remarkable delay to get this the 25 percentile to catch the early initiator. Again, the result was more prominent in active SBMS than the non-active SBMS. When it comes to 6 months confirmed cognitive worsening, again, it was more prominent in the early initiator of siponimod comparison with patient who started it late. Again, the result was more prominent among patients with active SBMS in comparison with non-active SBMS. Again, there was always delay in catching up with in group of patient of late initiator to catch with the 25 percentile of the early initiator of the medication. When it comes to annualized relapse rate, again, still the superiority of early initiator in comparison with the late initiator. However, if you look here, when it was also remarkable decrease in annualized relapse rate when compared the group with late initiator with the previous history when the patient group were in placebo arm. When it comes to the brain atrophy, again, the total brain atrophy still there's superiority of early initiator when it comes to total brain atrophy, thalamic volume also, and when it comes to gray matter, cortical gray matter volume, there was catch up by 60 months between the two groups, early and late initiator, and this was in fact explained by that there's remarkable or accelerated recovery of the cortical or response to the cortical gray matter in comparison with thalamic and total brain metrics. Now, when also it comes to comparison again of MRI between the T2 lesions, again the superiority is regarding if total T2 lesion volume, or when it comes to new or enlarging T2 lesions, again the superiority is prominent for the early initiator when it comes to the late initiators. So when it comes to safety, and again, this 5 years now follow-up confirmed the safety, and that we know, and there was no identified any new safety signal over the 5 years, and the all adverse events in fact are still compatible with what we know exactly on the S1P modulator side effect profile. The conclusion of this study was that continuous siponimod treatment demonstrated sustained efficacy on annualized relapse rate, total and regional brain atrophy, and inflammatory disease activity, and was associated with better clinical outcome versus the late initiator who were in placebo group during the core study. Now, continuous also siponimod treatment reduced the risk of 6 months confirmed disability by 22%, and 6 months confirmed worsening of CBS by 23%. Delaying siponimod treatment resulted in greater degree of brain volume versus the early initiator, and this was remarkable in all parameters or all endpoint of the extension study. No unexpected new safety signal for siponimod S1P modulator were identified in the long term, and this is in fact enhancing the safety that we know now on this group of medications since the first generation or first ancestor fingolimod till now. And this is the side effect profile and safety profile is confirmed now by siponimod and the extension study again. The sustained efficacy and consistent long-term safety profile of siponimod up to 5 years support its clinical utility in the long term. So we have some data that long-term, even it is long-term use of siponimod is effective and safe. And the benefit in the continuous siponimod group versus the placebo siponimod group highlights the significance of early treatment. And this is again exactly we have to mimic what our approach to patients with relapsing remitting. When we confirm that there's a treatment window, we have to grab this opportunity as early as possible in order to start treatment. Again, now we have opportunity to confirm the diagnosis and start treatment as early as possible, as we have evidence that starting early protecting against disability, against brain volume loss, and again against MRI activities. The conclusion of my presentation: more than 50% of patients with relapsing remitting multiple sclerosis are transitioning to secondary progressive multiple sclerosis within 15 to 20 years. Secondary progressive multiple sclerosis is negatively impacting activities of daily living of people with MS and their ability and capacity to work. Secondary progressive multiple sclerosis still underdiagnosed, still undertreated, and the EXPAND study was the first phase 3 trial of any disease-modifying therapy to demonstrate superiority over placebo in the very representative population of patients with secondary progressive multiple sclerosis. Now we know from the expansion, even the open label extension, that siponimod is effective, well tolerated, and it demonstrated manageable safety profile and was consistent. The effect was consistent over the time. And what we know from the S1, the extension study was consistent with what we know from early ancestor of S1P modulator of fingolimod. By this is my last slide, I think. Thank you very much for your attention. I'm waiting for your questions. Thank you very much. Am I on time?
Thank you, Dr. Shakra, for a very yes, perfectly on time. Thank you, Dr. Shakra, for a very comprehensive presentation from which we all learned all the updates related to secondary progressive MS and SIPONI mode in particular. So please allow me to take some questions. So the first question, if a patient came to you, to your clinic for the first visit, you don't know him or her, but you are doubting that the weakness he has, for example, in his right lower extremity is probably either a residual from a previous relapse or the patient is transitioning to a secondary progressive phase. Would he be a good candidate for SIPONI mode, regardless if he is still in the relapsing remitting phase or if he is or she transitioning to SPMS?
Thank you. It's a very good question, very difficult question, in fact. However, we have need to exercise in history and digging more in history in order to get information about if there was any history of relapses in the past, or the patient is only just worsening in mobility over years. Now, existing of previous relapses or previously receiving steroid therapy for an acute attack, this probably is an indicator for the history of relapsing remitting multiple sclerosis. You know, this is the differentiation between secondary progressive multiple sclerosis and the primary progressive multiple sclerosis, history of previous relapses and treatment. Now, no treatment, but if there are relapses, then we can consider this as secondary progressive multiple sclerosis. In the absence of any relapses in the past, we have to think about primary progressive multiple sclerosis. Different is the treatment is slightly different between the two groups of patients. Unfortunately, the parameters in MRI are not very helpful in distinguishing between the two entities now. But we have more to rely on our clinical history and to decide about the treatment. Now, if this is probably secondary progressive multiple sclerosis, at that time I decide to go to SIPONI mode. Yeah.
And knowing that cognitive impairment is one of the earliest symptoms of secondary progressive MS, was brain atrophy, decrease in brain atrophy, which was significantly detected in the SIPONI mode group in its initial trial, was this associated with the stability in the cognition of the patient or improvement in any cognitive impairment, or this was not tackled or studied in the initial clinical trials of SIPONI mode?
No, I think it wasn't. In fact, it was one of the secondary endpoint of the expanded trial. They looked at the brain volume at different levels. They look at total brain volume, thalamic volume, and cortical gray matter volume, and they follow patients for 2 years. And what they found that there is remarkable superiority of SIPONI mode over placebo, regardless of the parameters you are using. And it was more prominent, especially in second year after 24 months of using the SIPONI mode. Now, it was associated also in the same time with either improvement or stability in cognition in almost like 70% of population of the patient. And again, they looked at 6 months confirmed cognitive worsening among two groups, and they found that cognitive worsening among patients who received the SIPONI mode was less, statistically significant, also less than the group of placebo. So there is improvement in or stability, at least in the hardware, which is the brain itself, and in the software, which is the cognition. Yes, it was looked at in the first and expand trial. And the result was very, in fact, statistically significant, very much.
Yeah, we should here highlight as a clinician, as MS clinician, that in secondary progressive MS, we have different goals in therapy than in relapsing remitting MS. So it's not only about decrease the number and severity of relapse, and even the patient, if he has significant difficulty in walking or in ambulation, he can still benefit from SPMS therapy, because in the phase of the progression, we need to improve cognition, we need to maintain hand function, we have other function than walking that we need to save. So keep in mind this when treating your SPMS as patient, it's never too late or to treat those patients. So another question, Dr. Shahra, about genotyping. So are all patients, or does all patients need genetic testing before initiating siponimod in order to see the titration schedule for them?
Yeah, certainly they need. This is in fact an application, and all patients supposed to go to siponimod, they have to receive the cytochrome typing, and according to this typing, either they get the higher dose, which is 2 mg or 1 mg, and the very minimal, unlikely cytochrome type that was star 3, these people, this group of patients are not eligible at all to receive this medication. And I think the cytochrome typing or genetic typing is provided by for free by the company itself. Yeah, but all patients
So
here
is it
supposed to
done?
get
It is done. So like the JC virus for Tysabri, it's provided by the company.
Exactly, yeah. The genotyping for patient is provided for free by the company, and it takes probably
So
5
it's
or
under
5
the
days.
big research project,
Yeah,
right? It's
yes,
under
I think
research. It's
so.
done under
Yeah.
the research project.
Yeah,
Another
I'm not
question.
sure what it's done, but it's again provided by free by the company. Majority of patients, of course, are receiving the higher dose, 2 mg daily. Minority of patients are receiving 1 mg based on this typing. I haven't encountered any patient with star 3. It is they are extremely uncommon, I think, in community.
And if a patient develop lymphopenia on the higher dose, with fingolimod, the other S1P receptor modulator, whenever a patient have a lymphocyte count less than 200, we used to either stop for a period of time, then re-challenge, or we used to decrease the dose to every other day. What about siponimod? If a patient develop lymphopenia, severe lymphopenia on siponimod, would it be rational to, for example, decrease the dose if the patient is on the highest dose?
We usually follow, especially in fingolimod, we used to do the lymphocyte count every 3 months. If the number, if it is below the 100, then we stop the medication for 10 days and re-exam or redo the lymphocyte count. Yeah, but we don't usually go to every other day. Now in siponimod, I did not encounter any lymphopenia at all in among my patients. Still, the group is small in comparison with fingolimod. But again, the protocol, I think if you will stop the medication just now for 5 days, you have to restart again the initiating back or the starter back again. So you can stop, of course, the washout period is small. It's within 1 week to 2 weeks, you get the medication out of the body. And again, if you will challenge, you can restart with an initiative or starter back and follow closely the lymphocyte count. Based on the study, there was no severe at all lymphopenia that was necessary to stop the medication, and I did not encounter in my practice any low lymphocyte count. But if you will go to 1 mg instead of 2 mg, I'm not sure if this is a protocol that can be used or in a part of management, but I think we can probably stop the medication for 1 week or 2 weeks and again restart it again.
Rechange, yes. Another question, you mentioned herpes zoster as one of the herpes zoster reactivation as one of its side effects. So do we need to do a varicella zoster antibody pre-test as we usually do with fingolimod? And if the patient has negative antibody, we give the vaccine, and then after 1 month, once the patient develops positive titer, we start siponimod. Do we follow the same protocol as fingolimod?
Certainly, same as fingolimod, as also for other S1B1 modulators. Now we have many of these molecules available in the market. And yes, for all of them, same practice. You have to check for herpes zoster antibodies status. If it's negative, we have to proceed for vaccination. Then we have to start the medication, yes.
And a final question, not to delay Professor Majd. one of the audience is asking, can you summarize for us when is the appropriate time to start an MS patient on siponimod?
Again, it is same for relapsing rheumatic multiple sclerosis, as early as possible. Whenever you confirm the diagnosis or confirm that patient is transitioning into secondary progressive multiple sclerosis, better to start the treatment. Now you have evidence that late initiator, they don't act in same way as early initiator. Whenever it comes to progression of disability, whenever it comes to brain atrophy, whenever it comes to annual relapse rate, whenever it comes to MRI T2 lesions and active lesions. So again, you have enough now information that starting early is protecting your patient in secondary progressive multiple sclerosis more than it was started late. In fact, the catching patient in transitioning is very important. Unfortunately, till this moment, we don't have any biomarker to help us. We have to, if we are follow our patient closely, we know they are in fact transitioning to secondary progressive multiple sclerosis. When you don't encounter any relapses, you encounter some enlargement of T2 lesions in the brain, you encounter that patient is worsening in ADSS scoring, and patient starts complaining of different group of complaints that I mentioned as soft complaints when it comes to or some functional probably complaints like stiffness, like mobility difficulty, lack of concentration, difficulty in sleeping, bladder dysfunction, sexual dysfunction, fatigue. All these are prominent, the picture now of complaint than what they used to complain of motor weakness, ataxia, imbalance, optic neuritis, or something like this. So it's different complaints. Again, if you catch your patient, it is better to start as early as possible.
So diagnosing early SPMS and shifting patient as early as possible to this newly approved SPMS medication would have better outcome on our MS patient. Thank you, Dr. Shahra, for being with us tonight and for your time and for answering all our questions. With no further delay, I will move to introduce Professor Majd Zakaria. Thank you. Bye-bye. Who is joining us from Egypt. Professor Majd Zakaria obtained his medical degree in 1980 from the Medical School of Ain Shams University, Cairo. He then completed his master's degree in NeuroPsychiatry in 1984 at the same university. In 1989, he graduated with an MD degree in neurology and became a lecturer. And since 1999, Professor Majd is a professor of neurology at Ain Shams University. Dr. Zakaria was the head of the neurology department at the Ain Shams Specialized University Hospital, the head of the stroke unit, the head of the neuropsychiatric department of Ain Shams Medical School. He is currently the head of the multiple sclerosis unit at the same institution. Moreover, Professor Majd is the president of the Egyptian Society of Multiple Sclerosis, the president of the Egyptian National Stroke Committee. He is the Egypt's representative in the International Medical and Scientific Board of the Multiple Sclerosis International Federation, MSIF. He is also a board member of Menactrums and of the MENA Brain Health Champion. He is also representative of Egypt at the Multiple Sclerosis Global Advisory Network. Dr. Zakaria is also an active researcher and has in his record many publications in the field of neurologists with emphasis on multiple sclerosis. He is also a member of the editorial board of the journal Multiple Sclerosis and Related Disorder. Dr. Zakaria will share with you real-world clinical cases for discussion. I would like to encourage our esteemed attendees to actively participate in our case discussion by voting to the poll whenever needed. Professor Majd, I am honored to have worked with you during the preparation of the Menactrums Congress this year, which will be held in Egypt next November, and you are all welcome to attend. And we are always honored to have you as a speaker with us. Please start your presentation.
Thank you very much, dear Dr. Maya, for this very nice introduction. Although when you state the timing of the graduation, I start to feel a little bit old now. Of course, thank Novartis for this opportunity and for sponsoring these educational programs. And it's an honor to be with my dear colleague, Dr. Mustafa Shaqra, in this IVPN educational program. Now, after listening to this very comprehensive lecture from Dr. Mustafa Shaqra, we will have some thinking processes with actually it's one case. It's not many cases. It's only one case, but one case which reflects all the concepts that we have heard about secondary progressive and when to diagnose secondary progressive. It's very natural that when you see a patient with a cane, you will think of secondary progressive MS. But the problem is how to approach patients with secondary progressive MS from the very beginning, as we heard Dr. Shaqra saying that they can start at EDSS of 2 or 3. So the big problem is how to identify these patients in an earlier stage rather than a later stage. Now we have this female teacher, 42 years old, married with 3 children, no past history of medical conditions. She had a strong family history of breast cancer. Her mother and her sister had breast cancer. And in 2020, she presented with a partial cervical myelitis and urinary urgency. She was seen by a neurologist who requested an MRI. So as we can see on the right side, we have this cervical patch, maybe a little, not too long, but some gadolinium enhancement in the cervical patch, coinciding with the clinical symptomatology. And this was her brain MRI. You can see, I will stop the motion of the film so that we can see certain distribution of patches. Again. So we have here also middle cerebellar peduncle patches. And we have some confluent patches. And we have the classical periventricular patches, okay? So this was her MRI in the first presentation, and she was 42 years old. So her CSF showed more than 10 oligoclonal bands. The VEP showed well-formed potentials with increased P100 latencies of 135 and 140. And her serological tests were normal. She received pulse steroids for 5 days with incomplete recovery, and her EDSS was 2.5. Now, the first question is, giving these data, would you consider this case as a case of active relapsing MS or highly active MS or aggressive MS?
I would like to ask all our audience to vote. The poll just popped up on your screen. Please vote, and we'll give you around 6 seconds to end the voting. So here are the results, Dr. Majd.
Okay, so we have 38% active, 44 highly active, and 18% aggressive. Okay, so let us go to the definitions of the highly active and aggressive disease. We know that the definition of active disease by Lublin is that a patient who has had a relapse and with or without MRI activity, and in general with a low level of disability below EDSS of 3. Now, the highly active is always classified by having more than 2 or more relapses in the year before studying or in the year before evaluating this patient. And if they have received previous DMDs, then it is acceptable for more than one relapse in addition to some MRI activity. So by definition, highly active is either that you have 2 relapses in the previous year, or you have 1 relapse if you're receiving medication with some MRI activity. And the aggressive disease is characterized by the accumulation of disability. So you have mounting disability in a short period of time, or you have 2 or more relapses with incomplete recovery in the past year. So by definition, this case does not apply to highly active or aggressive because she has only had 1 relapse with some residual disability and an EDSS of 2.5. This is by definition. So which DMD would you choose for this patient? Interferons or DMF or fingolimod or ocrelizumab?
So I would ask our audience to vote, and just to clarify, DMS is dimethyl fumarate.
Yes. So we have interferons 35%, fingolimod 35% also, ocrelizumab 15%. Okay. So, of course, the problem maybe with ocrelizumab in this patient is that she has a very strong family history of breast cancer. And DMF and interferons are considered as first-line therapies. So, although by definition, this patient, as we said, could have active relapsing MS, but this patient has poor prognostic factors. That is, trying to. So we have prognostic factors for the evaluation of the patient whenever you see the patient in the very beginning, especially the treatment naive. Now, this patient has a lot of poor prognostic factors, and these prognostic factors are high risk for future disability. She is more than 40 years old, and she has motor and bladder presentation. She has partial recovery, and she has an abnormal MRI with gadolinium-enhancing lesions in the spinal cord and a lot of T2 lesions in the brain and posterior fossa lesions, more than 10 bands of oligoclonal bands. Although theoretically speaking, this patient is classified as an active relapsing MS, but she has many poor prognostic factors. And these again are the prognostic factors, and these prognostic factors are very important when you see the patient for the first time, because when you see the patient for the first time and you see all these prognostic factors, whether poor or good prognostic factors, then you can confidently assign medication to this patient and know what you expect in the development of the clinical disability afterwards. So I agree completely that this patient should have taken fingolimod because she has a lot of poor prognostic factors, and at the same time ocrelizumab would have been a good option if she did not have this very strong history of breast cancer. So she received DMF. This was not my choice, which is dimethyl fumarate, and remained stable till 2021, 1 year, when she presented with a left optic neuritis, but resolved completely, and unlike the first episode. And her MRI showed 2 T2 lesions more. Her EDSS was still 2.5, but she did a GC virus test and the index was 1.5. So the first question is, would you consider changing her treatment?
So please vote by answering yes or no. So
Okay.
here are the answers, Dr. Majd.
Okay. Yes, I agree, of course, with the majority who said yes, because we have activity. Now, with all the recent and modern medication, the concept of MIDA, which is minimal evidence of disease activity, which we used to adopt when we only had interferons, the concept has changed. And now, whenever you have activity, whether relapses or MRI activity, in a patient stable on treatment for at least 1 year, this means that the disease is not fully controlled. And this is something you do not want to follow up for your patients, is that you leave a patient with an uncontrolled disease. So probably the answer yes is the most appropriate answer, is that we need to change the medication because this patient is not properly controlled. Now, the question would be, which DMD would you choose? Which will you shift to? Will you go to fingolimod? Will you go to cladribine? Or will you go to natalizumab?
So please vote before we stop the voting and we show the results.
Okay. So
the answers are similar.
Yes, 38, yes, more or less similar. With natalizumab, of course, we have an index of 1.5. We know that maybe this could be acceptable to leave the index 1.5 up to 1 or 2 years, but at the same time, there is always this risk with an index of 1.5 JC virus. So could be under question if you're going to use natalizumab or not because of the index of 1.5. Cladribine, again, maybe cladribine could be a good choice, but at the same time, with the strong family history of malignancy, maybe you could hesitate to use cladribine, although the cladribine was cleared from the first claims when it was withdrawn at the beginning with malignancy signal, and afterwards a lot of analysis showed that this is not true. But again, you could hesitate for this strong family history. Now we know that there are risk stratifications with the natalizumab, the very huge retrospective analysis data, and showing that with an index of 1.5 in the first 12 months, the risk is acceptable. Maybe in the second 12 months, the risk becomes high. So if you use natalizumab, then you should have a full evaluation of the patient on short intervals, so that you don't miss any risk increase of PML. Now, the patient received fingolimod, and her EDSS was still 2.5, but she started performing additional tests like the timed 20-foot walk test, and it was 5 seconds, and her SDMD, the single digital modality testing, was 85. And for the timed 20-foot walk test, it's an easy test where you let the patient walk a distance of about 8 meters, 8.5 meters, which is the 20-foot feet. And the usual normal would do this below 6 seconds, let's say from 4 to 5 seconds. This is the normal, below 6 seconds. And her SDMD, which is a measure for cognitive function and speed processing, is very high. The SDMT has items where you should cover within 90 seconds, and the average score would be around 60, 65, something like this. And it depends, of course, on aging. Maybe it's stable until the age of 50, but after the age of 50, it goes slower. So 85 is a very high score. The maximum is 110, and usually the maximum needs more than 90 seconds so that you give. So she had a very high SDMD score and a normal 25-foot walk test. Now, she remained stable on fingolimod with no relapses or MRI activity. However, was complaining from excessive fatigue and teaching difficulties. Remember, she's a teacher. Now, her follow-up assessment showed that her time 20-foot walk test was 7 seconds. Now, it was previously 5.5 seconds, and her SDMD went down to 65 instead of 85, which is a very huge decline. And these findings were away from any relapses. There were no relapses. So this was a finding. You examined the patient, you recorded these parameters, and then after her follow-up several months later, you examined these parameters again, and then you found the parameters changing in the absence of a relapse. And the findings were confirmed after 3 months. However, when after 3 months the MRI was done, it showed a new T2 lesion. So what we have here is a patient, her EDSS is 2.5, but then we have decline in the time 20-foot walk test, and the SDMD confirmed after 3 months in the absence of a relapse, and additional new T2 lesion. Do you consider the change in this time 20-foot walk test and SDMD meaningful?
So please vote by answering yes or no if you consider the change in these follow-up test, clinical follow-up test meaningful. And remember, as Dr. Majd just explained, the 25-foot walk test is a walking test that assesses the walking ability of a patient, and the SDMT is another test that assesses the cognitive ability and the speed of processing of a patient. And usually those are performed at each clinic visit every 6 months. Here we go, Dr. Majd. 78% consider it meaningful.
Yes, okay, then this is very important, because now we are establishing that there are parameters that are changing in the absence of a relapse. This is a very important point. The whole idea of secondary progressive disease is that you are having progression independent of relapse activity. Now, the problem was that we are always looking at the EDSS, and the EDSS is relying on certain functions. But there are other parameters that should be looked and could be monitored as progression independent of relapse activity, like the SDMD and the time 20-foot walk test as part of the confirmed composite disability progression. Now, what is the current diagnosis with these new findings that have been confirmed after 3 months in the absence of a relapse? What is your diagnosis? Is this patient still having relapsing remitting MS, or is she starting to have active secondary progressive MS or inactive secondary progressive MS?
So please vote. What is the current diagnosis of the patient? And here Professor Majd highlighted a very, very important point that usually a clinician or neurologist might miss when assessing the efficacy of a treatment, which is that EDSS does not always reflect the progression of the patient. So keep in mind that we should do the other clinical tests that will detect minor differences that maybe for us as a clinician they are minor, but for the patient that they are major, they have major impact in their daily activities.
Okay, very good. So the majority chose that this patient has active secondary progressive MS, and I totally agree with this, because there is a new T2 lesion, and at the same time we are establishing the cornerstone of secondary progressive MS, which is progression independent of relapse activity. Now, going back to what Professor Shahra showed us, this is the classical view, the old view of secondary progressive MS. If you look at the curve here, this is what we call the relapse-associated worsening, which is present in the relapsing remitting phase. But once you start having progression, which is independent of relapse activity, then this marks the beginning of the secondary progressive MS. This is the classical view, or this was the classical view, is that you do not have progression independent of relapse activity, except late in the course of relapsing remitting MS. And in the relapsing remitting MS, you don't have progression independent of relapse activity, you only have relapse associated worsening. So this was the classical view until the definition, the definition Professor Shahra showed us, the brain definition 2016, where you do not diagnose secondary progressive MS except in a late stage where you have a minimum EDSS of 4 and you have to have a pyramidal function score of 2 so that you confirm. But the problem with this is that we are only relying on the EDSS, and that there are other domains that can show progression independent of relapse activity that could be documented earlier. And this progression independent of relapse activity is the cornerstone of secondary progressive disease. So we used to look at secondary progressive disease in terms of motor only and in terms of the EDSS. And this is why you do not see or you do not diagnose this secondary progressive disease except at the later stage, because motor is a later stage. And at the same time, you miss all the other evaluation that you could do earlier to document, again, the cornerstone, which is progression independent of relapse activity. And when the Kapos did this paper, the pooled analysis of Opera 1 and Opera 2, these were relapsing remitting cases with a mean and median EDSS of 2.8, not 4, 2.8. And they discovered that in the interferon arm and in the ocrelizumab arm, the majority of confirmed disability progression was progression independent of relapse activity. So in this paper, which came out in 2020, 2019, and presented as a poster first in the ECTRIMS in 2018, it became apparent that now we are detecting progression independent of relapse activity at a much earlier stage than we used to think. And again, mind you, that progression independent of relapse activity is the cornerstone of secondary progressive disease, which we used to look only in terms of motor and in terms of EDSS, and that's why it was late. Now it's coming early, or we're detecting it early. And here, of course, they used the combined the disability measure, which is the EDSS, in addition to the time 20-foot walk test, in addition to the 9-hole pick test. Okay. And Kapos came up with this curve in order to document the progression, which is independent of relapse activity. So whenever you have a relapse, it's stable. This is the relapse associated worsening. And then you make your measures and see if there is progression away from any relapse. Remember our case, she had more than 20% progression in the time 20-foot walk and was confirmed again after 3 months. So our case showed progression independent of relapse activity in the time 20-foot walk test, much more than 20%, because her scores came from 85 to 65. So it's more nearly 30%, something like this. So this is confirmed disability progression independent of relapse activity, again, which is the cornerstone of secondary progressive disease. So we have here two statements. The recent results, the recent studies highlight that progression of disability can occur in typical relapsing MS, and does so without the association of clinical relapses, underscoring the challenge in distinguishing relapsing remitting from secondary progressive MS. How much do you agree with this statement?
So please, you can write your answer in the chat box.
Okay, this is in a different format, so. Yeah,
in a different format, exactly.
Okay.
So if you would like, you can write your answer in the chat box.
And also with the second question also, so that they write only one time. So it's 1 and 2, let's say. And we can call the transitional phase the silent progression phase. Can we call the transition? Remember, silent progression was a term introduced by Bruce Cree, and he was describing the progression independent of relapse activity that is occurring from the very early stages of the relapsing remitting, but under cover of the relapse. So the problem is that in the beginning of the illness, you have a lot of inflammatory activity that covers this progression independent of relapse activity. But at the same time, in many of the recent papers, you will find that in a classical cohort of relapsing remitting MS, most of the confirmed disability progressions are progression independent of relapse activity.
So yes, the attendees who answered, they strongly agree for both questions.
Okay, very good. And here is a statement from the paper by Kappos, is that most clinicians would not consider patients with relapsing multiple sclerosis and a low level of disability to have secondary progressive MS. Like our patients, their EDSS is still 2.5, in which accumulation of disability occurs independent of relapse activity, despite mounting data that patients with relapsing multiple sclerosis frequently worsen over time. So the proper way to assess progression independent of relapse activity is not to depend only on the motor component, which is the EDSS, in addition to the time 24-walk test and the 9-hole prick test, which measures the function of the upper limb. So relying only on the motor component, this could show late, although we have papers like that of Kappos who showed the PIRA in a cohort of 2.8 EDSS. But we have to depend on other measures of progression, like the cognitive test, like our patient who showed cognitive decline, like the brain atrophy, which you can document, like the optic progression, which is using OCT. If you do serial measures of OCT for the patients, and you see that there is progression along the optic nerve in the absence of relapses, then you are documenting progression. So the whole idea, again, of secondary progressive disease is to document progression independent of relapse activity. And this is not only in the motor domain and not only in the EDSS, and this is why we all used to diagnose secondary progressive disease in a very late stage when the patient is coming with a cane. But this is all changing now. And all the recent literature is pointing out to the cognitive, to the optic. There was a very nice paper by Thomas Berger, 2020, a correlation between the OCT and the PIRA. And his cohort had an EDSS of 2. So all the recent literature is pointing out to the importance of documenting progression independent of relapse activity using multiple measures, not only the EDSS as seen in this screen. Now, the FDA has approved using most of the DMDs for the active secondary progressive cases. Do you agree with this statement?
So please vote by answering yes or no. So, do all DMTs are approved for the treatment of active SPMS? Yes or no?
Oh, they were approved by the FDA.
FDA, yeah.
Yes, but do the audience agree for this approval of the FDA? So the majority approve. Okay. Now, here we will have some discussion and debate with each other. Now, the FDA has approved using fingolimod, dimethylfumarate, all the cladribine, all the medication when you have active secondary progressive MS. Now, let us see how we evaluate things. In order to evaluate things in an evidence-based medicine profile or way or methodology, then you have to study the effect of any medication on this specific population. Now, all the approved medication being used in secondary progressive MS by the FDA, they have not been tested in this category of patients. If you see, as Professor Shara told us about the EXPAND, the mean EDSS was 5.6 to 6. The mean EDSS in all the relapsing remitting trials was 2 point something. Okay, so we're not talking about the same population. We're talking about a totally different population. And at the same time, in the EXPAND trial, we had 64% relapse-free in the previous 2 years. Now the medication approved for relapsing remitting MS, it is a must that you have relapses in the previous 2 years to enter the trial. Okay, so we are talking about two completely different patient groups, and in order to say that DMF or cladribine or any other medication approved for active secondary progressive disease is working, as the FDA said, then you should test it. But they were not tested, as simple as that. Now, if you see those who were tested mainly were the siponimod and the natalizumab in the ASCEND study. Okay, no, the slide is not there, but in the ASCEND study, the natalizumab is the super drug of the relapsing remitting MS, and yet the super drug of the relapsing remitting MS, when tested in a similar population to the EXPAND population, the natalizumab failed. So by sense, by logic, by evidence-based medicine, if natalizumab failed in a similar population to the EXPAND, is it that easy to say that all the other medication used in relapsing remitting MS would succeed? You have to try them, you have to test them first. So the only medication that was tested in a specific and representative group of secondary progressive patients with a mean EDSS and a median EDSS of 5.6 to 6, which represents the cases that we see, the only one that showed evidence-based success was siponimod. And all the others that were tested in the same category, like natalizumab, showed no success. And the others were given the approval without being tested in this category. Now, the problem is that now we're talking about patients that are having a high level of disability. Now, the concept is changing now. The concept is changing is that you are looking at PIRA, which is the cornerstone, again, of secondary progressive disease at an early stage, at a stage where you don't have this high level of disability. So do our medication work on this? I mean, if you diagnose a patient with an EDSS of 2.5 or 3 as having active secondary progressive disease, based on, like we saw in our patient, that there is confirmed worsening of the time 20-foot walk test or the cognitive function with the SDMD, and you confirm this. So this is documentation of progression independent of relapse activity. But do our medication work in this early stage? If you look at, again, what we saw in the pooled analysis of OPERA 1 and OPERA 2, we see that although, yes, the majority of the confirmed disability progression was PIRA, but this at the same time can denote another thing. If you look at the other end of this observation, is that maybe the medication, whether interferon or acrelizumab, is working to improve or to reduce the relapse associated worsening, but it is not working at the same way to reduce the PIRA. And again, look at these numbers on the right side. We will find that ocrelizumab reduced the relapse associated worsening with more than 53%, but less than 20% reduced the PIRA. So again, this raises a very important question, is that the medication doesn't seem to work on the PIRA the same way it works on the relapse associated worsening. And again, this recent paper for natalizumab, the same thing. You can see that only 9% did not have remained with relapse associated worsening, only 9%, but 24% had PIRA. So it seems the same thing, that the medication, whether ocrelizumab, natalizumab, is working very well on the relapse associated worsening, but much less on the progression independent of relapse activity. Now, this recent paper also by Bruce Cree is that they made analysis for the cases that showed activity and those who did not show activity, and they found that siponimod was working well in the both categories. And at the same time, as Professor Shara said, the efficacy is better when you detect the patients early. So it seems from the available data that the rest of the medication does not seem to work efficiently on the PIRA, but the only one tested properly was siponimod, and at the same time, the results were better when you have an earlier stage of the illness. An important question now, we diagnosed based on the time 20-foot walk test and the SDMD, which are progressing independent of relapse activity, that this patient is starting to have active secondary progressive disease in an early stage. So we want to shift to siponimod. She's taking fingolimod. Do we need a washout period?
So please vote to Professor Majd's question. Do we need a washout period when shifting a patient from fingolimod to siponimod, and knowing that both they are S1P receptor modulator?
Because it's all very recent, I can understand that many of the answers said yes to the washout period. From fingolimod to siponimod, they are both S1P1 modulators. Fingolimod is S1P1, 3, 4, and 5, while siponimod is S1P1 and S1P5. You do not need a washout period. You can directly shift from fingolimod to siponimod because they are the same category of drugs, classes of drugs. Do we need to titrate siponimod? So again, you shifted to directly, you shifted from fingolimod to siponimod. Now, do we need to titrate it as we do when we use it at the very beginning?
Please vote.
Is the answer delayed or I'm?
Yeah, we will run the answer now. See.
Okay. Okay. Again, this is an important point to correct. Again, I can understand that because this is recent. Still in practice, we have certain points that we are not sure of. But as before, that you can directly shift because they are the same class, you do not need to titrate. Why do we titrate? We titrate to avoid especially the cardiac effects of the S1P1, which is already there. So you are taking a drug that you already have been using for a long time, which is fingolimod, and it has all the effects that you need to titrate the siponimod for. So you do not titrate, you go to the full dose directly from fingolimod to the siponimod. There is a recent trial, which is called the Exchange clinical trial. It's going on now from shifting from medication to siponimod. It's still, the results are not clearly published. And you can go to this trial and see that the majority of cases were from fingolimod to siponimod, and there was no problem, as we said, whether washout or titration or whatever. The last thing is that the cytochrome, which metabolizes the siponimod, is the cytochrome 2C19. You remember, if you remember from epilepsy, this is the cytochrome that metabolizes the phenytoin. Okay, so whenever you have a cytochrome that is metabolizing a drug, then there are certain drugs that are inducers and certain drugs that are inhibitors of this cytochrome. So there is some drug interaction with different medication. There is a drug interaction between the siponimod and modafinil, which we use frequently in MS. There are interactions between certain antidepressants and siponimod, which we use frequently in MS. And there are interactions between siponimod and prednisone, which we use in MS, not prednisolone, but prednisone. So it is important when using siponimod, and probably this is a request for our dear friends from Novartis, that maybe they give us a list of the possible drug-drug interactions and the end result, whether the increased potency or the decreased potency of the drug according to which type of medication has the interaction with this. Sorry for being late, and it's a pleasure and honor to be among you all. Thank you.
Thank you, Professor Zakaria, for a very, very enriching presentation. We will take some questions. Actually, we do have questions. So the first question, do we need the cardiac monitoring for siponimod like fingolimod, or can we skip, since we are titrating the siponimod dose? So can we skip the cardiac monitoring?
Actually, we are doing the titration to skip the cardiac monitoring, except in certain conditions where you have a past history of myocardial infarction or certain blocks. But as Professor Shara said, we do not need to do the cardiac monitoring with the siponimod because of the titration, the method of titration.
Another question, do you think that primary progressive MS, so with the new Lublin reclassification of the multiple sclerosis phenotype, do you think that primary progressive MS and secondary progressive MS are one disease?
Personally, they are different. My personal opinion is, of course, they are different. They are different even in some pathological changes. Maybe the overall pathological changes are the same, but the distribution of the pathological changes and the sequence of the pathological changes are different. And at the same time, even if you look at the MRI of a patient with secondary progressive disease and an MRI, the brain MRI of a patient with primary progressive disease, you can easily differentiate between the two. Sometimes you have patients coming to us maybe with a history of a minor relapse, but with progression, and you're not sure if this patient is primary progressive with some relapses, or he is relapsing remitting or a secondary progressive case. If you look at the MRI brain, in a case of primary progressive disease, you will find much less activity than secondary progressive disease. You will find in the secondary progressive disease a lot of brain atrophy, a lot of confluent lesions. You do not see this in the primary progressive cases. You see a lot of spinal load, but you do not see all these changes in the MRI brains of the primary progressive disease. So they are different, at least in management, because we have different clinical courses. They are grouped together as progressive, but in my personal opinion, it's different.
So given said that, Professor Majd, so a patient who is diagnosed with PPMS should be maintained on ocrelizumab, which is a drug approved for primary progressive MS, while a patient who is labeled with SPMS should be maintained on siponimod, and both drugs cannot be used interchangeably for progressive disease, right?
Right.
Great. Thank you, Doctor, again, for this presentation and for accepting our invitation. And with Professor Zakaria, excellent case discussion session, our second virtual clinic comes to its end. Thank you for our esteemed speaker, again, Professor Shahra. Thank you, Novartis, for staying with us until the end. I would like to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you miss any part of this webinar or would like to revisit the lecture, you can check our IVPN NeuroPsychiatry library, where we post all the recordings. Also, don't forget to follow us on our social media platform and stay tuned for our next virtual clinic in June 22, which is next week, during which we will discuss anti-CGRP treatment for migraine. So keep your eyes on our page, as all the details will be announced very soon. And I would like to take the opportunity that Professor Majd was with us today to invite you all to our 7th Menactrums Congress, which will be held in Egypt next November. I think Professor Majd would like all of us to come to visit Cairo and benefit from the updated information about MS that Menactrums usually provide on yearly basis. And until we meet again, stay safe and have a good night.
Thank you very much.
Thank you.
Excellent
Thank you.
presentation, Majd. Raya. Thank you. Good night. Bye-bye.
Good night. Bye-bye. Bye.
Thank you.
Bye-bye. Thank you. Thank you.
Bye-bye.
Bye.